Thank you, Deborah. Let me see if we can go ahead and get started. On behalf of myself and my co-moderators, I'd like to welcome everyone to this session. We're very excited to take part in it. And at the outset, I want to thank the ACPMP for their support. So my other co-moderators throughout the day are going to be Dr. Laura Lambert from the University of Utah and Dr. Kieran Taraga, who was at the University of Chicago and recently relocated to Yale. So on behalf of all of them and myself, let me see if we can go ahead and get started. So this is essentially the 101 class, if you would. So I'm here to give you sort of an orientation for those of you who are new. And to those of you who experienced, you might see some of that. And I've been asked to bring this back from my previous discussions before. First, and I think most important, what I want to say to everyone in attendance is that when most patients come and see me, and I've seen close to 1,000 patients with this diagnosis, you're not alone. Most people who are coming in with this diagnosis have never met, many of them have never heard of this diagnosis of appendiceal tumors or appendiceal cancer. You're not alone, and frankly, on the call and on this session today, there are hundreds of people sharing the same problems and issues that you're sharing from a number of different countries. And at least virtually, I think we'll give you an opportunity to meet some of them today. Now, one of the things I need to say at the beginning of this talk is that if you look at National Cancer Institute funding, it's awarded pretty much by incidence. And if you look at the number of cases of different types of cancer, which I put up on the screen here, lung cancer, 250,000, breast cancer, close to 300,000, colon cancer. Many, many times in cancer, the appendix is way down there at the bottom with close to 3,000 cases, which to me is 3,000 too many. But that's the way that the National Institutes of Health has awarded funds. I'm very proud to say in the last year and a half, we have been awarded 2 grants from the National Institutes of Health and the National Cancer Institute to study cancer of the appendix. And the seed money to get started with this came in part from the ACPMP. So please support the ACPMP and the research agenda, because if you look at the return on investment for what we've got, which is over $5 million in research funding just for this at our site alone, probably your best investment. All right. Warning, and for those of you old enough to remember Lost in Space, warning, Will Robinson, I will actually show you 2 pictures of what these tumors look like. Okay, so for younger and more sensitive viewers, you might want to just turn your head away at certain of these parts or just listen. So let's talk about appendiceal tumors and appendiceal cancer. Appendiceal tumors, most of them are benign, actually, not malignant. There's roughly 10,000 a year in the United States. And I say roughly because we do not have really good numbers in terms of benign diagnoses. Most of the malignant diagnoses go into cancer registries, and the numbers are pretty tight. For benign ones, that's a guesstimation. They are more common than the malignant version, and they're usually incidental. Most of the time, people are not going to come in complaining of something in the appendix. They're going to come in with something that looks or feels like appendicitis. They'll take it into the operating room, and they take the appendix out, and they'll take something in the appendix. And what you see here, I hope you can see my mouse there. That's a laparoscopic view from a laparoscope from what an appendiceal tumor looked like in one case. And here's one they took out before and after they opened it, and you can see all the mucin inside. We're going to spend a lot of our time talking exactly about that. There's a wide variety of benign tumors. I'm not going to spend a lot of time talking about them. For simple appendiceal processes, if the tumor is completely removed for a benign tumor, that's curative. And everybody likes to know about celebrities who have had this sort of problem. The most famous person I can find with one of these was Dan Quayle, who was the vice president of the United States a few years ago, who had trouble spelling the word tomato, if you recall. All right, now let's pivot and talk about the malignant subtypes. Currently, it's about adenocarcinomas or gland cancers, and a mucinous variety is probably a little bit more common than a carcinoid. It used to be the other way around. And I think those numbers have shifted over recent years. To make it more complicated, as rare as these appendiceal tumors are, There is a wide variety of different types: mucinous, adenocarcinomas, manic, well-differentiated, poorly differentiated, goblet cell, signet. There's a wide variety of these sort of appendiceal neoplasms. Now, the good news is the talk following this one is by an expert pathologist. So I'm going to try to fly low over pathology, but I think give you an idea of what you're looking at. These other types of tumors, lymphoma, GI stromal tumors, those are extremely rare. So let's talk about this. How do we find these tumors? Can you find them by endoscopy? Actually, we looked at that, and I looked back at patients who came in with massive appendiceal tumors, and we looked at 191 consecutive cases with preoperative colonoscopy, most of them within 6 months. And colonoscopy only found these tumors in 3% of cases. That does not mean the gastroenterologist, the surgeon who is doing the endoscopy, missed it. It just means you have to remember from anatomy, the appendix is an offshoot of the colon, and you can't actually drive the endoscope into the appendiceal lumen. It's too small. So you're rarely going to find anything. Sometimes you'll find a mass effect. Of note, close to 40% of patients had additional polyps in the colon at the time of colonoscopy. Not cancer, but additional polyps, which tells you that if you are found to have one of these appendiceal tumors, and you're going to be going for definitive surgery, a colonoscopy to look at the rest of the colon, which is at risk, not for tumor spread from the appendix, but for other tumors that just happen to be there, is significant and should be performed essentially routinely. Now, PMP is part of the title of the supporting organization, so I have to define what it is. This is a brand new diagnosis, first described in 1884. So I'm bringing you state-of-the-art technology here. And it's a syndrome of mucinous ascites. So it's fluid in the peritoneal cavity, which is the definition of ascites. And you got sort of a picture of it here, and this is what this mucin looks like. It actually doesn't look like jelly to my view, unless you thin it out a little bit. For those of you who are chefs, it resembles aspic. And it is absolutely mucus. So it is thick and it's viscous. And the reason that's important is you can't draw it out with a needle. It's like putting a needle into a jar of grape jelly. You can't possibly draw the fluid or the mucin out with a needle. So you're going to have to go in and essentially operate on these to remove them. The vast majority of these mucinous ascites or PMP cases come from the appendix. Now, not all appendiceal cancers, when they spread, cause pseudomyxoma. Most do, but not all. The pseudomyxoma can come from either low-grade or high-grade, and left untreated, the chance of making 5 years without definitive surgery is less than 10%. Chance of making 10 years without definitive surgery is close to nil. Now, removing the mucin is helpful. It can relieve symptoms, but it is never curative. The way to cure this tumor is to remove it. So you have to take out not the mucin. The mucin is a byproduct. The pseudomyxoma is a byproduct. What you have to remove is the cells in the peritoneal cavity that produce the mucin. And unfortunately, left untreated, pseudomyxoma is essentially uniformly fatal, and most patients are going to die of bowel obstructions or something like that. Now, this is a rare tumor, but it's increasing in incidence. So these are two different studies from two different institutions. And what they show is from 1970 to 2010 or 2000, the incidence of these tumors is going up substantially, somewhere between 50 and 250% over the last 40 years. Now, does that mean it's becoming more common? Perhaps. I think more likely, due to organizations such as this, we are probably having a lot more understanding and a lot more accurate diagnosis from pathologists and other physicians who are aware that this is a real syndrome that it has to deal with. Carcinoid tumors are a totally different breed of cat. The rules of engagement are quite different. Most of them are in the distal tip. They never cause pseudomyxoma. And they are good candidates for cytoreductive surgery. However, HIPEC is much less effective for these tumors than it is for other tumors. I'm not going to spend any more time talking about that. The other thing I have to say is there's been recently some substantial improvements in the systemic therapy for carcinoid tumors, not so much for the mucinous tumors. All right, now let's come down to cases. What I think most people are on this session for is to talk about appendiceal cancer. And again, I have to put up some celebrities who have suffered with this disease. Stuart Scott's a sportcaster, Audrey Hepburn, of course. Both of them died far too young of this disease. And what should you do if you find these appendiceal tumors? If there's any surgeons in the group, if you find it and you don't know what you were up against, stop, put your pencils down, remove the appendix, and get out. Send it to an expert center. Once you find it, there are tumor markers which we can send. The classic ones are CEA, CA19-9, and CA125. There's probably an emerging role for something called circulating tumor DNA or ctDNA. You'll probably hear a little bit more about that later in the talks, but that's essentially a fancy tumor marker. So there's going to be roughly 3,000 cases in a year, 2,500 that are ruptured. Look for second primary. Those are your tumor markers. And the prognosis is closely related to grade, and we'll take you through that. And the pathologic descriptors here are crucial. I cannot emphasize enough how important it is to have good pathology support in terms of evaluating and figuring out how to treat patients who have got this disease. To make it yet more complicated, the further back you go in time, the less organized the pathologic descriptions were. The way the pathologists have classified these tumors has changed substantially over the past few years. You're going to hear in the next talk more about this, but I'll take you through this in just a couple of minutes. What's more, most surgeons who are operating on appendicitis are really not prepared to encounter appendiceal cancers, appendiceal tumor, or pseudomyxoma. Again, this is a retrospective report we did in the last couple of years. We looked at the quality of operative reports for patients who were found to have appendiceal tumors. 44%, the surgeon took out the appendix and didn't even look around. There's no mention of was there tumor spread, was there not, was there mucinous ascites, was there anything else going on. 48% had only a partial. We looked around a little bit, but we didn't take a comprehensive view when we saw a tumor. Less than 1 in 10 is actually going to find it. Now, most general surgeons in practice are going to encounter 2 or 3 of these in a career. So most surgeons are not seeing this every day. It's my job to try and let people know. And when you go to community reports compared to expert centers, somewhere between 15 and 30% of the patients who sent in their pathology reports had them substantially revised once they get here. And again, I cannot emphasize enough the importance of finding an expert center. So there's several different systems. You're going to hear about these. There's the original system came out in 1995. Now, 1995, for those of us with a little gray hair, it's not all that long ago. Before that, the descriptors of this tumor and this process were all over the map and very difficult to understand. Frankly, I prefer a 2-tier system rather than a 3-tier system, low grade and high grade, which is also preferred by the Memorial Sloan Kettering group. There are bad actors, which are called signet rings and goblet cells, but there are signet ring features, which are bad, but not particularly bad. And to qualify as a signet ring cancer, there are specific criteria that a pathologist is going to want to go through. Now, in an effort to unify the pathology, WHO, that's not WHO, but World Health Organization, the World Health Organization came up with what they call a fascicle or a publication to try and unify what goes on. It's an excellent classification. One of the co-authors of that fascicle is going to talk in just a few minutes. The problem is not all pathologists, not all pathology departments, not even all expert centers utilize what's in that WHO fascicle. So beware of confusing descriptors and changing rules because the further back you go in time, the more complex it becomes. This is a picture of the World Health Organization. This came out in 2019. And again, that is not all that long ago for a disease which has been known since 1884. So we're making progress, and you can understand the importance of pulling together a lot of assets and expertise for such and such as this to make things better for people going forward. The grade 1 are what we call low grade, high grade, or what we call grade 2 and 3, which means somewhere in between is an intermediate grade from the original system in 1995. And quite frankly, that's going to fall in the eye of the pathologist. So let me show you some pictures of what these tumors actually look like. And there's a picture worth 10,000 words. And I hope you can see my mouse here. So this is a photomicrograph of 40 times X. So this is really enlarged. Here you have a large lake of mucin. Here you have a lot of fibrosis around the outside of the tumor. And this thin line right here, those are the actual tumor cells. Not a whole lot for causing as much mischief as they do. And this is a low-grade tumor. And you can see the amount of fibrosis around it as the body's trying to wall this off. The key is not just to scoop out the mucin, because the cells will still be here doing what they're doing in their little mucin factories. They'll continue to crank out the mucin and they generate the scar. What leads to bowel obstructions and problem is this thick tissue right here. That's all scar tissue right there, form of scar tissue. So this is a low-grade tumor with relatively well-behaved cells. And you can see that it would not be hard to imagine there's a break over here on the bottom where there's no mucosal lining, none of these tumor cells, but you still have the scar. See if we can move on to a higher risk one. There we go. This is the more high risk, and you can see the little blue dots in there. Those are cancer cells that are now in between in that scar tissue. So these cells are now invading into the scar tissue. You still have these big lakes of mucin out here, but you can see they're walled off and segmented into little micelles or little areas. That can make these things difficult to clear. Now let me go back here. This is the high-grade version, and you can see you've got those cells like that, but now you've got cells that are breaking off and floating in the mucin. They're waiting to land somewhere else and spread the process. So that's low, intermediate, and high-grade tumors, at least by most definitions. Now you can, you can take a look here and you can see you don't have to be an expert. You don't have to be a statistician to figure out that there's a lot going on here between low, intermediate, and high-grade tumors. The high-grade do far worse than the low-grade. We've actually looked at genomics or genetic expressions, the first genetic expression study that was done, and you can actually figure out just by the genes that are active in the tumor who's going to do well, who will not do anywhere nearly as well. We then looked at the same sort of thing. We looked at genomics in a whole new way, and the most common genes that are mutated in here are GNAS and KRAS. You'll hear a lot more about this in some talks shortly, and even in this early genetic analysis, colorectal cancer is substantially different than what we find for appendiceal cancer. There's a larger studies of what they call precision medicine. There's a couple of them here from two different companies do a lot of this, Foundation One or Caris. They both find the same thing. GNAS and KRAS are very common. There are very few what they call actionable mutations, and the mutation profiles are completely distinct from colon cancer. This is a totally different disease from two different separate agencies, separate pathology houses which do these sort of analyses. And this is a report from one of my patients. And although next generation sequencing came with a great deal of excitement and has been very helpful for a wide variety of tumor types, it has not been anywhere nearly as exciting for appendiceal cancer as we had hoped. There are very few which have got a high mutational burden, which makes it a target. KRAS and GNAS do not have really good targets for molecular drugs, and they're not particularly immune responsive, so some of the new checkpoint inhibitors have not been particularly effective. However, we can use these genetic analysis to find some specific targets. These are two drugs which are currently available for appendiceal cancer, GNAS and KRAS, and you'll hear more about this from the Norwegian lab of Dr. Flatmark. We'll be talking in a little while. So what do we learn from genetic analysis? Appendix cancer is clearly distinct from colon cancer, and genomics, I think, can be very helpful. They can help us define signatures and targets for additional treatment. So how do you treat this? These are your real options for systemic therapy, immunotherapy, targeted treatment, radiation, etc. Radiation you don't do almost ever. Cytoreductive surgery and HIPEC are usually what we're going to do for most folks. You're going to hear about chemotherapy from another talk coming up later today. Chemotherapy, and this is a study that we did with the MD Anderson and found actually, unfortunately, chemotherapy had an objective response rate, which is low. Most of the objective responses are limited to high-grade tumors. And it's not curative. It can help, but it's not really curative. And if you're going to treat with chemotherapy, the goal should be stable disease. So for cytoreductive surgery and HIPEC, the goal is to remove all the peritoneal disease. This is the surgical version of what the military would call a search and destroy mission. We want to get you down to minimum residual disease, and we want to be able to deliver some chemotherapy into the peritoneal cavity, if feasible, to kill any microscopic cells which are likely to remain. How do you do it? You choose patient that you have to have a confirmed diagnosis. The primary has got to be resectable. All the disease should be resectable optimally, or at least maximally debulkable. It's good not to have disease outside the abdomen. These appendiceal cancers tend not to spread outside the abdominal cavity very often, and you have to be medically fit for a major operation. These can be very substantial operative interventions: cardiac, pulmonary, nutritional, performance status, and frankly, emotional status as well as support team. So most of these people will be seen by anesthesia. Everybody gets antibiotics, and we're going to give people, there's a fair amount of support we're going to go through to start with. The goal of this operation is to remove all the disease. The goal is complete cytoreduction whenever you embark on one of these procedures. Then to run the chemotherapy run, we want to deliver that in a uniform fashion throughout where we're at and throughout the entirety of the peritoneal cavity. What you have here is something called, everybody's heard of a blood-brain barrier, perhaps. This is a plasma peritoneal barrier, and this is the ratio of what's in the peritoneum versus what gets into the bloodstream. And some of these drugs, particularly like oxaliplatin and mitomycin C, have got an advantage or a selection gradient somewhere between 25 and 75 to 1. So by delivering the chemotherapy into the peritoneal cavity rather than into the bloodstream, you can deliver far more tumor to target than you ever could with even the most aggressive dosing. We score how much disease in the abdomen with something called a peritoneal cancer index, or the PCI. You'll hear that. It's sort of a complicated system that goes 0 to 39. I'm not going to take you through that in much more detail. And then that's the PCI score is how much disease is in the peritoneal cavity when you start. This is how much disease is in the abdominal cavity when we're done. So it can be either R for residual, CC, or completeness of cytoreduction. They're actually pretty similar. What we're looking for is R0 and R1 are essentially the same, only microscopic residual. CC0 and R2A is the same, R2B and C, and CC2 and 3, bulk residual disease. We want to avoid that when you can. And again, this is what these things look like, and this is some of our experience here at Wake Forest. And I'm showing this not because it's unique, because it's similar to other major centers, but this shows you what the differences are in terms of the resection status. Now, here you've got chances of being alive and years after surgery. This is a 10 years out right here. And if you have a significant complete cytoreduction, you're looking at 70 to 80% survival rate, particularly for low-grade cancers. If you have a high-grade tumor or you have nodal metastases, the numbers go down from there. So complete resection, near complete resection, and these are just major debulking procedures. And again, you can see the substantial difference in outcomes. So the surgeons are going to work very hard to do this. We also looked at what kind of shape you're in. If you're in good shape, which is these top lines here, when you come for the procedure, you do far better than if you have substantial symptoms, which means you don't want to wait for major symptoms before you intervene. That is not a good plan. Cannot recommend that to you. Additionally, these are learning curves for 200 cases apiece. The first 200 cases, we didn't do nearly as well as we did since. And that tells you that the learning curve for these procedures in terms of centers and surgeons is substantial. So what's prognostic? Histologic grade, performance status, or PCI resection score, nodal disease. These are things that we're going to be looking at, but it's grade and resection score, how much disease is present. Those are the key prognostic indicators. There's only been one prospective randomized trial. I'm just going to fly this over quickly. I'm proud to say we headquartered it here at Wake Forest. This is the only prospective randomized trial that's been completed for cancer of the appendix looking for antineoplastic treatment. And we randomized patients who had cytoreductive surgery and HIPEC for appendiceal cancer to mitomycin versus oxaliplatin done in the operating room. It took me 6 years to do this at 3 major centers. This was a major undertaking. It's basically a decade's worth of work. And what it shows is there's differences in terms of the white counts. This is the white count days after surgery here. And the white count, just like whenever you get chemo, even if you get into the peritoneal cavity, is going to send your white count down. It turns out the mitomycin will hold your white count lower than the oxaliplatin will. It's a little bit easier on platelets, though. But what most people want to see is who's alive and who's not. Whether you're perfused with oxaliplatin or mitomycin doesn't seem to make a whole lot of difference. Whether you stratify them by how complete the cytoreduction was or just by the drug. So that's sort of where you're at. There was a slight difference. This is TOI, which is a quality of life index. And what you can see is at 3 months, the quality of life index for everyone goes down. The blue line is the oxaliplatin line. The other line is the mitomycin. So for appendiceal cancer, we found a slight improvement in quality of life for people who got the oxaliplatin and perfusate. So what did we learn? We can do prospective randomized trials. They're not easy. They're difficult to do because it's a rare process. We need cooperation of a large number of centers in order to do this, but it's certainly possible. I'm going to skip to a couple of these. Quality of life slides. And what do we learn from quality of life studies? Quality of life won't come back after these big operations for 1 to 6 months. This is a big operation. Long-term quality of life in survivors tends to be maintained. And we find sleep disturbances and depression in substantial numbers of our patients. So in long-term surveillance, we're going to be screening for that. We also looked at the caregivers of patients in a separate study. And what we found is that the caregivers have actually got a harder impact of their quality of life than the actual patients. Patients tend to get over this and move on. Those of us or those who care for patients who have undergone this procedure takes quite some time to get through. We ask a lot of our caregivers, and for those who are on this session, I applaud you and I thank you for what you're doing for our patients. We must include caregivers in what we're doing, and we need additional support. Financial worries after this operation could be substantial. There's a number of ongoing research projects. This is actually a shot of bromelain, which we'll be hearing more about. That's from our Australian colleagues. And before the sun sets on my talk, I want to leave you with these points. First, this is a rare disease, but increasing in incidence. Grade and resection status are the key prognostic indicators, and experience is important. If you find yourself being faced with this challenging diagnosis, get yourself to an expert center. The complication rates of this procedure are substantial. They can be life-changing. They can also be life-saving. Long-term survival is certainly possible. We've got patients who are more than 20 years out and have never had a recurrence. But unfortunately, not everyone is able to achieve that. We have ongoing genomics research. You'll hear more about that. Organoid research, you'll hear more about that. Clinical trials are important. And frankly, support ongoing cancer research, support appendiceal cancer research. That is how we make the treatment better for everyone. So from our center to yours, after more than 30 years of hand-to-hand combat with this disease, thank you for your attention. Welcome to the session. And I think we're going to get to questions later. Remember to use your Q&A. We'll be getting to that a little bit later in the day. And I'd like to see if we can now move on to move on to our next speaker. So our next speaker is Dr. Joseph Mizrahi, who is an expert pathologist from Yale, New Haven. And I'm pleased that he's there with a microscope. If you didn't know he was a pathologist, that is always a telltale sign. And let me give Dr. Mizrahi the floor. Thank you.
Thank you very much, Dr. Levine, and thank you to the Laura Lambert for reaching out. I just want to make sure that you can see my slideshow.
Okay. Yeah.
Okay, great. And my pointer, is that working? Great, thank you. So thank you for the ACPMP for inviting me to speak to you. And it's a rare day that pathologists get an opportunity to speak to patients and their family members about diseases. I'm in my office, which looks especially sparse because I've only been here a short while. But I wanted to show you that this is the tool that we often use. It's a microscope. This is how we often intervene in patient care. It's looking at slides. It's rendering a diagnosis under the microscope. And because of that, pathologists have a unique perspective of looking at tumors and being able to classify them based on what they look like. So we are keys to the pathologic classification of tumors. And we're going to talk about the pathology of the appendix and pseudomyxoma peritonei. So to begin this, I want to just mention where the appendix lives normally. It is a small appendage that resides at the end of the colon, close to where the small intestine joins the colon. And it looks like a pinky finger normally. Here it's been detached from the colon. This is what it looks like. You can see it's tan and not dilated. And this sleeve of tissue here is fatty tissue. And this is where the blood vessels travel to reach the appendix to keep it alive, of course. Now, we've just taken a slice through the appendix, and we're going to look under the microscope, and there are several layers to this. It is a hollow organ, so in here is the hollow center, and then it is lined by a slippery lining called the mucosa. And each of these structures that dives down here are glands that produce mucus or mucin. And this entire layer is known as the mucosa. And if you touch the inside of your cheek with your tongue, that's also a mucosa. It's a different type of mucosa, but you get the point. It's a slippery, wet lining. These are immune cells, and we're not really sure what the appendix function is, but one proposed function of the appendix is to teach immune cells to deal with the numerous bacteria that live inside the colon and to handle those. These bubbles of clear areas are fat cells, and this kind of pink material is collagen. So this layer is under the mucosa. It's called the submucosa. And then this thick pink band is what we call the muscle wall. The entire gastrointestinal tract has this wall, which squeezes the GI tract to keep fecal matter moving and food moving through the GI tract. So let's talk about what is pseudomyxoma peritonei. Pseudomyxoma peritonei is a term that is used for mucinous tumor deposits in the abdomen due to spread from a mucin-producing tumor elsewhere. And in case there's any confusion, mucin is very similar to mucus. For decades, it was thought that it arose from the ovary. And this is because many women who have pseudomyxoma peritonei also have mucinous tumors within the ovary, and they're often quite large. But today we know that it actually usually arises from an appendix tumor, and it has spread to the abdomen. And if the ovaries are involved, it is also spread to the ovaries. The appendix is not the only organ from which it can arise. It can arise from other organs, such as the colon, the pancreas, etc. And yes, even rarely the ovaries, but by and large, the appendix is usually the culprit. And this is an example of pseudomyxoma peritonei. This structure running along the top of the screen is the colon. And this membrane that is reaching down from it is the omentum. And some of these tan lines are blood vessels. Now, this should be a relatively translucent, thin membrane, but you can see that it's coated with this glistening kind of nodular tissue. And here it is cut on a cut section. And you can see that it looks like a glistening bubble wrap. Again, these kind of yellow tan lines are blood vessels. And so this should be very thin, and instead it's a very thick cake-like material that is coating the tissues in the abdomen. This is an example in the ovary. The ovary should look like a white kind of like gristly tissue. And instead, this ovary has been replaced by this material that is often likened to currant jelly. Now, appendiceal tumors and pseudomyxoma peritonei have a long history of having multiple and confusing names. Now, why is that the case? I think the number one reason is that they challenge conventional notions of what we consider benign and what we consider malignant. So what are those conventional notions? When we think about a benign tumor, it should show relatively bland or innocuous looking tumor cells under the microscope. They do not metastasize, and they are cured when you excise them by surgery. Most malignant tumors show clearly abnormal cells that invade normal tissue under the microscope. And when they metastasize throughout the abdomen, they would be rapidly progressive and often fatal. Now, to understand those concepts, I want to detour for a moment to the colon, where things are a little bit simpler. This is a colon that's been opened. This lining here that looks folded and glistening is the mucosa. And then what's abnormal here are these numerous growths that look like warts. These are polyps. Now, when people say they have polyps in the colon, they usually have one or two or a few. And this is obviously an extreme number. This person has a syndrome that they produce a lot of polyps, and that's why they took this picture. So these are numerous colon polyps. Now, we've taken a section, we're looking under the microscope. Now, here's that pink muscle layer that I said the entire gastrointestinal tract has. This is that slippery lining called the mucosa, this lining right here with glands that produce mucin. And what's abnormal are these mushroom caps that are sitting on top of this mucosa. Those are abnormal. And we're looking now closer. And here's again that lining of mucosa. These are the glands that produce mucin. And here we have this growth on top of it. And you can see that it's a little bit different. It's definitely darker than this. And it's still these are called glands, these tubular structures. And it's sitting on top of the mucosa. It is not invaded underneath this mucosal layer. Down here, these spaces are blood vessels. And this tumor does not have access to blood vessels. So if you remove it, it had no opportunity to spread throughout the body, so it's benign. So we would call this an adenoma. Adeno is Greek for gland, and these are forming glands. Oma is the suffix for benign tumor. So by saying adenoma, we mean a benign gland-forming tumor. And here is a malignant tumor. So here is that normal mucosa layer. Here is the benign part. But in this case, you see that now these little tubules or glands are invading underneath the mucosa. Now they have access to here, the blood vessels, and can start to spread. Here's another blood vessel. So by gaining access to this area of the submucosa, it is now has access to spread throughout the body. So this is an adeno, meaning gland, carcinoma, meaning malignant tumor, or adenocarcinoma. And when it is spread to the abdomen, you see glands or these tubules inside the abdomen where they don't belong. We should find fatty tissue, as we see here, and some collagen, but no glands. So this is spread of that colonic tumor to the abdomen. So we call this metastatic adenocarcinoma, or malignant gland-forming tumor that has spread. So in the colon, the terminology is fairly simple. We have adenomas, that's benign. We have carcinomas, that's malignant. And then they have metastatic carcinomas. And that's the basic framework for most tumors in the body. Now, do we have that framework in the appendix? To some extent, we do. Let's look at this appendix. This appendix is clearly dilated and it's been opened, and you can see that it's spilling mucinous material inside it. When we look under the microscope, that normal slippery layer, the mucosa, has been replaced by this kind of frond-like growth within it. But you can see that it's confined to the inside of the layers here. It is not invading. And here's a reminder of what the appendix should look like. These are the normal glands. We don't see this frond-like growth. But again, it's confined to just the center. When we look very closely, this is the normal. This is what our tumor looks like. And you can see it's a little different. These are a little bit darker. They're a little bit more crowded. They're kind of on top of each other, but not too different. So these are what we call low grade. They're very similar to normal. So we would say this is an appendiceal adenoma, or a benign gland-forming tumor of the appendix. Here's another appendix tumor. Here's the center, the lumen. There's this growth within it, but now you see that there's invasion of the appendix wall by all this complex gland-like growth. So we would say this is an appendiceal adenocarcinoma because it's invading the appendix, a malignant gland-forming tumor in the appendix. But from here, things get complicated. So yes, appendix tumors can be clearly benign or clearly malignant, just like they can be in the colon. But the appendix tumor that most commonly results in pseudomyxoma actually has features that make it difficult to classify as benign or malignant. Let's look at this example. Here's an appendix. It's clearly pretty dilated, and most of it looks pretty smooth, but there's this little mushroom cap of mucin sticking out of it with this hemorrhage around it. So there's been a rupture of this appendix. When we look under the microscope, that mucosal layer looks a little abnormal. Even from way up here, we can see that it's a little bit abnormal. And while it hasn't invaded through that pink wall, it's sort of squeezed out. And by squeezing out, it's gotten the opportunity to spread that mucin and some of those tumor cells onto the surface of the appendix. So what do we say about this? Do we say that this is a benign tumor that has ruptured? Possibly. But when we look in the abdomen, again, we see here's blood vessels, and we see that this has caked the structures in the abdomen with this glistening tumor tissue. And when we look under the microscope, we see that that tumor tissue is composed of this gray-blue material. This is all mucus. This is collagen. And floating in that mucus, we can see these strips of cells. These are tumor cells that look very similar to the ones that were in the appendix. And when we look at higher power, we can see that the tumor cells are not very abnormal. They're a little bit abnormal, but they're still growing in the abdomen, producing all this gray-blue mucus relentlessly. So now what do we say about this? Do we say that this is a benign tumor that has spread to the abdomen, or do we have to say that this is metastatic cancer? Now, in the 1990s, pathologists at Johns Hopkins University introduced a term for this classic pattern of pseudomyxoma peritonei, and they called it disseminated peritoneal adenomucinosis, or DPAM for short. Let's dissect that term. Well, disseminated means it has spread around. Peritoneal means inside the abdomen, and mucinosis means an accumulation of mucin or mucus. Now you'll notice that these terms do not imply that this is malignant. And so the implication was that this is a benign process that is spread throughout the abdomen. Now, some pathologists just couldn't wrap their minds around the fact that a tumor that is spread around the abdomen could be benign, so they refused to use this term. And so this caused a lot of controversy. So summarizing the controversy, what we know is that the tumor in the appendix is composed of cells that are not very abnormal looking, and it doesn't exactly invade the appendix. So it seems to be a benign tumor that is pushed through the wall. But this tumor also has the capacity to spread throughout the abdomen, which suggests a malignant behavior. Now, classic pseudomyxoma peritonei does have some important differences from other tumors that spread throughout the abdomen. For one, it tends to coat the surfaces of organs rather than invading into them. Also, the tumor cells in classic pseudomyxoma look very bland and only mildly abnormal, whereas most malignant tumors in the abdomen look very abnormal. It's also only slowly progressive compared to most malignant tumors that spread throughout the abdomen. So again, it sort of challenged some of our notions of what is benign or malignant, which means that different pathologists were using different terms for these cases. And some pathologists could reconcile that this is a benign tumor that is spread throughout the abdomen. And there are certainly other examples of benign tumors that have perhaps more unusual features and even aggressive behavior. And other pathologists were using malignant terminology. And this caused a lot of confusion. Patients didn't know if they had cancer. Oncologists or surgeons didn't know how to address some of these cases, particularly if patients moved from one institution to another and the pathology traveled with them and their slides were reread by another pathologist who had a different viewpoint, and then they got a different diagnosis from a different institution. So while pathologists were arguing about what was the best way to classify these tumors, patients were left confused. Oftentimes the oncologists and surgeons were confused as well about the nature of this disease. Our group at Mass General Hospital came along in 2003 and proposed a term to describe these tumors called low-grade appendiceal mucinous neoplasm, or lamin. So let's dissect that term. Well, low-grade means bland or innocuous looking. Appendiceal means from the appendix, of course. Mucinous means the tumor produces mucin. And the key word is neoplasm. So we introduced this word neoplasm, which is a generic name for a tumor. It does not commit to whether this is a benign or malignant tumor. So we were basically saying, let's stop arguing about whether this tumor is benign or malignant. We're going to call it a tumor, a neoplasm. And we know its behavior, that when it pushes through the appendix, such as in this case, where it is ruptured right here and formed this extrusion of mucin, it can travel and spread throughout the abdomen. So we can start discussing and researching and communicating about this tumor and stop the argument about whether it's benign or malignant. And this created an uneasy truce. Now, it took years for this name to catch on. It wasn't until 2010 that the World Health Organization adopted this term to describe these tumors. And even still, people had uneven adoptability about this term. So it has slowly gained traction, and now it's recognized as the most common cause of pseudomyxoma, although not the only one. Also, the term low-grade appendiceal mucinous neoplasm indicates that the tumor is bland. But what happens if we have a tumor where the tumor cells are very abnormal? They introduce the term high-grade appendiceal mucinous neoplasm for one of these tumors that pushes its way through the appendix. But when you look under the microscope, the tumor cells are very abnormal. Here's an example of one of those tumors. We see inside the layer that there's this frond-like growth that's very abnormal. It's not invading most of the appendix, but here it has started to push through the appendix, just like one of those low-grade tumors. But when we look at the tumor under the microscope, here's our low-grade version. Look how ugly these tumors look, and this very twisted looking cells, very abnormal. So we call this a high-grade appendiceal mucinous neoplasm. Now let's turn our attention to pseudomyxoma peritonei. This is another entity that for many years had different pathologic terms, depending on whether the pathologist viewed the process as spread of a benign tumor or de facto malignant. And these are some of the benign tumors, benign terminology that was used for pseudomyxoma peritonei, and other centers would insist on using malignant terminology. Now, actually, just a few years ago, the term pseudomyxoma itself was adopted by the World Health Organization to describe pseudomyxoma peritonei. So let me just explain that the term pseudomyxoma peritonei was never considered by pathologists to be a term that should be in our reports. We considered that a term that was a clinical term. This is what the surgeon saw. This is what the radiologist saw. But we would use terms such as this in our pathology reports, and we would avoid the term pseudomyxoma peritonei. And so a few years ago, when we were trying to decide on a term that we could all agree on, that did not indicate whether you thought it was benign or whether you thought it was malignant. And let's, again, stop arguing about the nature of this process. We thought, well, we all understand what we mean when we say pseudomyxoma peritonei, so let's accept that term itself. And so this is a relatively new change. A lot of people are not even aware of this change yet. It's only been a couple of years. And so again, there's a process of educating people to use this term and to use it appropriately. Now, one of the things that Dr. Levine mentioned in his talk was that grade matters in pseudomyxoma peritonei. So I want to talk about that momentarily. What is a tumor's grade? The grade of a tumor is a description of how well the tumor recapitulates normal tissues. So when we say a tumor is low grade or grade 1, we generally mean that it looks very similar to the types of cells from which it was born or that it's recapitulating, and that it's less aggressive than a tumor that looks very abnormal or has a high grade and is grade 3 or 4. Classic pseudomyxoma that we've looked at already is low grade or grade 1. So let's take a look at that. This is classic pseudomyxoma peritonei. This is in the abdomen. A lot of this little tiny white bubbles are fat cells, but these large gray lakes are mucin or mucus lakes. And if we look inside those lakes, we find the telltale tumor cells that are producing that mucus. And this is just collagen. So these tumor cells don't look very abnormal. So this is low grade, and this is a grade 1 pseudomyxoma. Here's another example where we have these lakes of blue mucin, but now we have many tumor cells. They're forming a lot of buds and complex growth. And when we look at higher magnification, we see that the tumor cells are very abnormal, piling on top of each other. They're very large. They have these big nucleolus. They're very irregular and angry looking. So we would say this is a higher grade pseudomyxoma peritonei, or grade 2. In the last 15 years, there's been a lot of interest in signet ring cells. So here in the abdomen, we see these pools of mucin, but now the tumor cells are these single little cells that look like what we call signet ring cells. What are signet rings? Signet rings are ancient rings that are used by kings to put insignia on wax, on documents or letters, etc. I'm sure you've all seen similar things. And you can see why the tumor cells are called signet ring, because the nucleus is pushed to the side as it is here, and the mucus it's producing is inside the cytoplasm. And so when you get them just in the right angle, they look like signet rings. And you can see them here infiltrating between fat cells. Now, why are they so destructive? Well, let's compare them to these two groups of protesters. Here we have protesters that are locked arm in arm, and here we have protesters that are marching single file. And if I were to ask you which of these groups would be more likely to be able to infiltrate into a vanguard of, let's say, police officers that were trying to stop them, you would say, well, this group has a better chance of infiltrating between the police officers, because they can obviously get between the police officers much quicker. These guys, unless they release each other, they're going to have a hard time getting through the vanguard of police officers. And that's exactly the same for pseudomyxoma. These cells in the tumor, in the low-grade pseudomyxoma, are holding on to one another. And so their capacity to infiltrate into tissue is limited. Signet ring cells, by virtue of the fact that they are single, can infiltrate into the tissues more readily. And this is borne out by the prognosis. So patients with low-grade pseudomyxoma peritonei do better over the long term, and you can see that the slope of the prognosis does not decrease as quickly as it does with patients with grade 3 or signet ring cell pseudomyxoma peritonei. And so this is the 3 grades of pseudomyxoma peritonei next to each other. So you can see the low grade has a lot of mucin with very few innocuous looking tumor cells. Grade 2 has more tumor cells that are more abnormal. And grade 3 has numerous tumor cells that are present as signet ring cells. So we've come a long way in our terminology. As Dr. Levine mentioned, if you go back 20 years, the terminology was very confusing. Today, it is markedly improved. Today, we recognize that most pseudomyxoma grade 1 is caused from low-grade appendiceal mucinous neoplasm. High-grade appendiceal mucinous neoplasm or appendiceal adenocarcinomas, when they spread to the peritoneum, they tend to produce pseudomyxoma peritonei grade 2, and adenocarcinomas with signet ring cells or goblet cell adenocarcinoma, which I did not discuss, but when they spread to the abdomen, they produce pseudomyxoma peritonei with grade 3 or signet ring cell features. It's been a long road, but there's more to go in educating people to use terminology consistently. And with that, I'm going to stop sharing, and I thank you for your attention.
All right, thank you, Dr. Mizrahi. I think that actually it's very nice making a complex problem, I think, to understandable. And now we know how to infiltrate a police line if things get rough. So that's actually a very informative talk. Now, the next 2 talks are going to be a little bit different. We're going to be talking about therapies. We talked about diagnosis, overview, how the pathologist looks at this. The next 2 talks, we're going to be talking about therapies. So our next speaker is Dr. Ardaman Shergill from the University of Chicago. Dr. Shergill is a medical oncologist who specializes in GI cancers, and is going to talk to us today about treatment of patients with appendiceal cancer. Dr. Shergill, the floor is yours.
Thank you, Dr. Levine. I'm going to double check. Can everybody hear me?
Yes.
Yes, please go right ahead.
Perfect. Thank you. So I thank all the organizers and all the speakers for letting me talk about chemotherapy and appendix cancers. Next slide, please. These are some of my disclosures. I will also discuss the data in appendix cancer for use of chemotherapy and support in how we sequence chemotherapies are somewhat lacking, and that's one of my disclosures as well. These are our objectives. As discussed, this is just a brief overview. Appendix cancers are extremely rare, many times diagnosed incidentally because patients present with abdominal pain or appendicitis. And about 1% of appendectomy specimens would show appendix cancers. So many times they're diagnosed post-operatively after we take the appendix out. Prognosis of appendix cancer depends on the histopathologic subtype. And risk factors for appendix cancers are really unknown. Certainly inflammation, if there's underlying inflammation, but more than that, why a patient develops a certain kind of appendix cancer, that is unknown. I wouldn't spend a lot of time on this. I only put this up to say that there are the neuroendocrine neoplasm, the non-epithelial appendix cancers as well, which I would not focus on in this talk as we talk about therapies. I'm sorry, the slides are kind of jumping. Okay, I can move this slide. So as far as prognosis, we heard some of these numbers earlier today as well. This was a retrospective review of a single institution looking at about 100 patients with appendix cancers. As you can see, the prognosis depends on the histopathology, the stage of diagnosis, as well as if a patient underwent surgery, what kind of cytoreduction they have. For example, in low-grade tumors, the median overall survival is in the range of about 8 years in this particular study. As opposed to the signet ring cell adenocarcinomas, the median overall survival was about 2 years in this study. Similarly, for lower stage, the survival was not estimated in this study, but generally higher than what would be in a high stage tumor. If the cytoreduction was complete, meaning CC0 cytoreduction or CC1 cytoreduction, the survival was higher in the range of about 8 years, as opposed to CC2 or 3, where the survival was in the range of about 2 years. So all those things are important as we think about chemotherapy or therapy planning for appendix cancers. As was discussed already, the appendix cancers do have a high propensity of metastasizing to the peritoneum, which is the inside lining of our abdomen. The metastases to other solid organs is rare. So it's rarer to find metastases to the lung or liver, as can be seen in some of the other GI cancers. Appendix cancers can go into the lining of the lungs. We've also seen it in lymph nodes in the lung when we've done biopsies for patients. So that can happen, and whether it's direct tracking, I'm not sure. But we do see distant metastases in that sense. But primarily, the metastases are seen in the peritoneum or on the organs inside the abdomen. So we have to think about, how do we manage our patients appropriately? The primary treatment is if we can do surgeries and do HIPEC for patients, that's how we can take the tumors out and treat the tumor. But how do we get the patient to that if the disease is quite spread? HIPEC is heated intraperitoneal chemoperfusion that you'll hear about much more later today. I do want to mention that is not the only kind of chemotherapy we can give to patients in that setting, because the penetration of HIPEC is only about 2 to 5 millimeters. So you need some other systemic therapy to help control the disease. So what are some things we think about as we make decisions for how to approach a patient's care? We absolutely need multidisciplinary teams. The medical oncologists and the surgical oncologists, along with our radiologists and our pathologists, are helping us determine that plan. Ultimately, we want to get up to the point of CRS and HIPEC if possible for a patient. So we try to decide if upfront CRS HIPEC is possible, and is a complete cytoreduction possible in that case, or should we do upfront chemotherapy, try to see if we can get the disease controlled and then get to CRS HIPEC and have a better chance of getting the complete cytoreduction. We think about some patient-related factors like comorbidities as well as fitness for surgery and chemotherapy. We think about the burden of disease and symptoms a patient might be experiencing. as well as something called performance status, which you may see in our notes quite a bit. What we are assessing is how does a patient spend most of their time? Are they up and about most of the day? Are they resting half of the day or more than half of the day? And that has been associated with tolerance of treatment. There are also tumor factors, what type of appendix cancer it is, what is the surgical plan eventually. Grade plays a big role in making decisions for chemotherapy. I think the previous talks have also highlighted the role of how low-grade or high-grade appendix cancers. There's also grade 2, the intermediate grade appendix cancers. Generally for low-grade, we tend to do surgery first. Those tumors are usually slower growing, so the role of chemotherapy there is secondary. There are some cases or some times when we would consider chemotherapy, but it's not the primary therapy for low-grade tumors. Higher intermediate grade tumors, we do consider chemotherapy in those cases. Chemo can be given either neoadjuvant, meaning before a surgery, or in a perioperative setting, which is more common. Perioperative means there's some chemo that goes before the intended surgery and some chemo that goes after the intended surgery. Looking at, let's say, a patient presented with earlier stage cancer, they had a complete cytoreduction, and we're looking at their pathology. Which patient should get adjuvant chemotherapy? Which patient should get chemotherapy after their surgery? In other cancers, like in colon cancer, there are criteria that are helping define that. But in appendix cancer, same criteria actually didn't match out. The one thing that did portend benefit from chemotherapy in the adjuvant setting was lymph nodes. If the disease had spread to lymph nodes when the tumor was taken out, those patients did benefit from adjuvant chemotherapy. However, again, as I mentioned previously, these data are not as robust. These are retrospective studies looking at databases where the pathology is different, the terminology may be different, and the accuracy may also be different. And retrospective studies have many biases, so we have to take all of these data with a grain of salt. So could there be a patient who did not have lymph node positive disease, but we are worried enough that we would offer chemotherapy to? There could absolutely be, and those are the discussions we would have in our tumor board. This is looking at the role of systemic therapy in low-grade mucinous appendiceal neoplasms and showing that chemotherapy actually did not improve outcomes for patients. This is looking at survival. This was another study, retrospective, looking at role of chemotherapy in the adjuvant setting for low-grade tumors, where the chemotherapy played a role, and they divided tumors up as low-grade or non-low-grade. So anything that was not low-grade was the other category. And the benefit was only seen in the non-low-grade tumors rather than the low-grade tumors when adjuvant chemotherapy was being considered. This is looking at survival and the relapse probability, again, for low-grade and non-low-grade. As you see on the top, the two curves either overlap or they crisscross, but at the bottom, there's clear separation of those curves. So at the bottom, the non-low-grade tumors benefited from getting chemotherapy. Patients who got chemo in the adjuvant setting had better survival and relapse-free survival. The data to who gets chemotherapy and what kind of chemotherapy comes from very limited set of studies. There are a handful of prospective studies. I mentioned the COMBAT trial here, which actually was an older study. It was in 2015 that was published. It's a prospective single-arm study in colon cancers, but there were about 10 patients that had appendiceal cancer and were included in this study. In this study's patient got perioperative chemotherapy, so before and after. They got FOLFOX or FOLFIRI, and in this study, they also got cetuximab. The progression-free survival was about 15 months for those patients. However, single-arm studies and single-institution studies are hard to generalize because there are no control. There was no data on the subtype of appendiceal cancers, and of course, the number of cases was only 10, so hard to extrapolate from them. There are several retrospective studies with mixed results that are looking at perioperative chemotherapy. In fact, many of those studies show that the perioperative chemotherapy may have detrimental effects, but we have to look at these very carefully. There is a lot of selection bias when in those studies. Patients who actually go on to get chemotherapy and didn't get upfront resection probably had more advanced disease or concerning features where chemotherapy needed to be offered first. So there is a selection bias, and so we have to look at the outcomes in that respect. Also, the chemo agents in some of the studies was not specified. The type of appendiceal cancers that patients were, the type of appendiceal cancers that were being looked at were not always specified in these studies. And then also in some databases, HIPEC is not appropriately reported. You know, sometimes it's considered systemic, sometimes it's not. And so it introduces kind of this gray area in the data that we have to keep in mind as we review these studies. So right now, this is how, you know, our treatment paradigm or my treatment paradigm for appendiceal cancers is. So if we are thinking chemotherapy for patients, we would think about a perioperative approach upfront. I usually would do 2 or 3 months of chemotherapy and then rescan. Patients could get up to 4 months of chemotherapy before considering treatment, even up to 6 months. We assess response by looking at the scans. We'll assess response by looking at tumor markers if they were elevated. In addition, we are using some newer techniques that I'll talk about. And then also sometimes laparoscopic look, we have to take a look inside to see, because scans don't always pick up everything that we want to look at to make those decisions. If we think, you know, the treatment had a response and there is a chance of having CC0 surgery, then patient may proceed with cytoreduction and HIPEC. Once they've recovered from that, they would come back and see me again for additional chemotherapy. We think about total 6 months peri-op based on trials in other diseases, and then we try to complete that. What do we do after that? That is also unknown. You know, there are going to be patients who have high risk for recurrence. Do we maintain them on something? Do we kind of watch and closely monitor and treat if there is disease recurrence? Those are not well understood. And as far as the choice of chemotherapy, I listed some regimens here, and I'll go over them in a minute. This is to say, you know, I use this paradigm fully knowing that there's still many unanswered questions. Is 3 months of systemic therapy appropriate? What is the appropriate regimen when I start for a patient? How do I assess response appropriately? How do I know that the treatment is doing what I want it to do? Many times we kind of see stable disease and stable results, or maybe we see tumor markers coming down. We feel encouraged, but is that associated with long-term outcomes? Again, we don't have those data. CRS HIPEC, do all patients need chemotherapy after that? Are there patients that could be spared? What should be the additional chemo if the patient didn't have a great response? Again, those questions are still unanswered. And actually, you know, my area of research, my area and interest of research. This is looking at perioperative chemotherapy, and I wanted to show one study where patients who actually got perioperative chemotherapy had a histologic response. So on their pathology specimens, there was indication that chemotherapy had worked. They had a longer survival probability at many years, about 10 years out, compared to patients who did not. So this study at least supports, you know, doing the chemotherapy and seeing if patients have response so that we can have a longer survival probability rather than kind of, you know, trying to just get to chemotherapy and then doing what we can do afterwards. So that's our basis for kind of looking at perioperative approach for our patients. As far as high-grade disease, in high-grade unresectable disease, this study looked at systemic therapy as well as use of intraperitoneal chemotherapy. And here we see that the systemic therapy did provide disease control. And I include stable disease when I say disease control, not necessarily reduction, but even if disease is not growing as rapidly, in more than half of the patients with systemic treatment. Systemic meaning chemotherapy treatments. If you added HIPEC, it added additional benefits. So there was some benefit of doing HIPEC even in high-grade disease. And I think our group has published on that, where we have a paradigm for iterative HIPEC in patients who are not resectable. Limited data, just our experience, but something that we are trying to study more. Here are the choices of chemotherapy. So the backbone of chemotherapy is going to be 5-FU. Or capecitabine. 5-FU and capecitabine are equivalent drugs. Capecitabine is oral, 5-FU is IV. We can add oxaliplatin or irinotecan, or both oxaliplatin and irinotecan to that backbone. We can also add antibodies like bevacizumab. Use of other antibodies like cetuximab, which are EGFR antibodies, actually has not shown too much benefit on right-sided colon cancers. We expect that even in appendix cancers. We don't know, but it's not commonly something that I use for patients with appendix cancer. We have to be careful as we use bevacizumab, especially as we're thinking about surgery. So I give it for a few cycles, and I would hold it about 4 to 6 weeks around the surgery. So 4 to 6 weeks prior, 4 to 6 weeks after surgery, for patients to allow bevacizumab to go out of their system. It takes about 6 weeks to decrease bevacizumab, to get to the half-life of bevacizumab. And then if patients are progressing on chemotherapy that we've offered, or there's recurrence and they have progressed on the treatment, other options could be regorafenib or Lonsurf. These are drugs borrowed from colon cancer literature. This is also when I start looking at the molecular profiling of the DNA. Actually, I should say I look at the molecular profile at diagnosis, because I want to use all of those data as I make decisions, especially if I find a driver mutation. That's not standard, but we do work outside the box. We try to get drugs for patients where we have reasonable data, even if it's in other cancers, to see if that could be beneficial for patients. So how do I molecularly profile the patient? We look at the tumor itself. So we look at the DNA of either the biopsy or the surgical specimen, as well as the RNA, and we're looking for mutations. If we see mutations and we have medicines that can target those mutations, and we think that's what's making the cancer grow, then we would try to find those medications, at least in the refractory setting, to help patients. There's another ways, because maybe not always a biopsy is possible. We look at something called the liquid biopsy, which is all cancer cells, as they're growing, can shed some DNA into circulation, also shed some RNA into circulation. So these would be a blood test, and they pick up those. There's a panel of mutations that the liquid biopsy can test for. So they're trying to see if, when we do the blood test, are these mutations present? Commonly, they are from the cancer. And then we would know if a patient has a particular mutation or not. There are even more kind of newer techniques for the liquid molecular testing. We can actually get very, very specific to the tumors. These are called tumor-informed testing, where we can look to see in the circulation of a patient's blood whether there's any DNA that we think is coming from cancer. Such a technique can be helpful in monitoring cancer. There are plenty of data in colon coming out in some of the other GI cancers, as well as breast and lung cancers, and our group working on the appendix cancers, to see if this technique can be used in addition to our current existing CT scans, as well as tumor markers, to pick up cancers, at least their recurrence, as early as may be possible. So this is, I think we saw something similar to this earlier today, looking at mutation profile of appendix cancers, which is distinct from right or left-sided colon cancers. Most striking difference I see is, BRAF mutations are quite frequent in right-sided and a little less frequent in the left-sided, as well as in appendiceal cancers. There's also the ARID1A. I pointed that out because there are new drugs coming out to target that mutation in some other cancers. APC and PIK3 are much more common in right-sided, left-sided colon cancer, less frequent in appendiceal cancers. And then the KRAS mutation is fairly common in all cancers, the right, left, and the appendiceal cancers. And then GNAS mutation that we talked about and we'll hear about a little bit more later today. So this slide is mostly kind of pointing out that appendix cancer has its own unique mutational profile. It's its own organ. It is not right-sided colon cancer or left-sided or even small intestine. So we have to uniquely think about it and especially study drugs in that setting. What are some new targets and drugs that are coming up? So some things have been approved that are tumor agnostic. Some of those are fusion. So those are RNA-based tests, again, could be done on the tissue or the liquid biopsy that I mentioned. Those are something like NTRK or RET fusions or ROS fusions. We have drugs that can target these fusions, and they have approval in what we call tissue agnostic. So it doesn't matter what the origin of the cancer is. If we see that, we can request drug to target those fusions. The incidence of those is very, very, very rare, less than 1% in all cancers, and even rarer in appendix cancers. So when we find it, it's very helpful, but most of the time we don't see those mutations. There are KRAS G12C inhibitors, so a particular type of KRAS mutation that have approval. There are ongoing studies looking at those. There are also newer drugs coming up, and we have some phase 1 studies that we are opening up, looking at pan-KRAS inhibitors or other kind of KRAS mutations that hopefully will generate more data and targets for appendix cancers as well. There's approval for MSI-high cancers, extremely, extremely rare in appendix cancers. But if we do see it, and I have not seen a patient with MSI-high appendix cancer yet, there's approval to use immunotherapy in that setting. I also wanted to point out NCI's combo match. This is NCI's effort in looking at biomarkers. So we're looking at indications or biomarkers, could be mutations, that don't have approval yet in that particular cancer. NCI did a match study. So if a patient had a mutation and there was a drug available, patient could go on to the study and see if that drug is going to show a signal. This is the next effort, looking at combination. It could be a mutation, and if the patient has 2 drugs that could be targeted, or 2 mutations and 2 drugs that could be targeted, or chemotherapy combined with a target. I am, for example, the co-study chair for one of the combo match arms. It's looking at KRAS mutation. We have a pancreatic cohort, but we also have a tumor agnostic cohort, which is where I would expect to see our appendix cancer patients enrolled. So patients who have KRAS mutations could get binimetinib and palbociclib, the CD4K inhibitor, on this study. These are small studies. They're meant to be signal finding. If we see signals, we can expand on them and then study them in further detail. This is just one example. There are many other cohorts and sub-studies for combo match. We expect that this would open likely at the end of this year or next year. It was actually expected to open last year, but several delays in such a big project are expected. And here I wanted to show our work on some of the ctDNA testing. So here we are looking at a test called Natera. There are many platforms like this. Natera is one that we used. It is a tumor-informed assay. What does that mean? It means that the test actually looks at the DNA of the tumor and identifies certain unique sequences of DNA that are only present in the tumor. Then they test the blood and they try to see if those unique sequences are in the blood. So that's how they can detect even the smallest amount of cancer that could be there. That's called a tumor-informed assay. There are many other assays that are coming to the market. Some of them are not tumor-informed, use slightly different science and technology. But a lot of work going on, and I think our group is trying to kind of create a trial around this work. So I present data from about 6 patients that we had over the last couple of years that we were following. The gray kind of circle is the ctDNA, so the test when it became positive. The red triangle shows when we saw, if the ctDNA was not there, we were looking for recurrence for patient. With CT scan or laparoscopy, the red dot is when we would have detected recurrence. And the CEA, the green squares, is when the CEA, one of the tumor markers, would have been positive. This is, obviously very limited data. There's only 5 or 6 patients here, but we put it up to kind of show that ctDNA may be a tool in appendix cancers. Most of our patients here had high-grade disease, at least in this slide. We have more work coming out soon in some other grades as well. But here, most patients had high-grade cancers. These tumors can shed DNA into circulation that can be picked up, and we can use that as a monitoring tool for patients. In this very limited data set, we had a lead time of about 2 months, so 2 months before CEA or imaging or laparoscopy showed recurrence. But take it with a grain of salt because it's a very limited number of patients. We obviously need more research and more data in this field. And whether a 2-month detection lead time translates to improvement in patient outcomes, right? We don't know that, and we haven't studied that here. So challenges, we lack well-controlled studies to guide systemic management. There are also challenges in measurement of disease. How do we reliably detect recurrence? And because these patients are because of these challenges, patients are best evaluated at high volume centers. There are many unanswered questions. I think I mentioned most of these already. And then I thank everybody, and I thank all of you for your attention.
Thank you, Dr. Sturgill. That was an excellent talk. And again, a very complicated topic. And I think we're going to move on to our next speaker. Because we're running a little bit behind. Our next speaker is Dr. G. Weldon Gilcrease, who is an associate professor of medical oncology at the University of Utah at Huntsman Cancer Center. And he specializes also in gastrointestinal cancers. He's going to be talking to us about immunotherapy. What the heck is it anyway? Dr. Gilcrease, you're good to go.
Yeah, well, thank you. And really what an honor to be part of this meeting and part of this panel, but also, I especially want to thank the patients and family members. I really put this talk together to try to make sense of that specific question. And let me see if I can share my slides here, if I have permission. Let's see here. Okay. So that's actually exactly what I wanted to address. What is immunotherapy? And when we say that, what do we mean? I have a lot of patients that'll come in and say, well, I heard about stem cell therapy or these new CAR T cells. So where are we in this field? And I think Dr. Sturgill did a great segue for me in trying to give the larger picture of what kind of therapies do we have available for appendix cancers. I think one of the real challenges, and I'm sure every patient, family member, or physician that takes care of a lot of these cancers know this. Look at the number of patients that were on a lot of the studies that we saw. We saw one that had 10 patients. We saw one that had, I think, about 60 patients. We're not in the breast cancer world where we have thousands of patients on a trial. So I think it becomes very challenging to try to figure out how to manage each specific patient, which is an opportunity to personalize our treatment, but it is also a big challenge because we're often not guided by a lot of data that's out there. So I wanted to go through what is immunotherapy, and I was told I have 15 minutes, so I'll try to stick to my time here. And why is it so important? Why has it so completely changed the last decade of being a medical oncologist? So what I'm going to be specifically focusing on is those with appendix cancers that has spread or metastasized throughout the abdomen or peritoneum or even above the diaphragm to the lungs, et cetera. And can we use immunotherapy in those patients? So what is it? If you look at this cartoon drawing, on the left, you'll see on the top those orange red cells. And if you're colorblind, I apologize. But on the top, this is either a tumor cell or an immune cell that's within a tumor that's trying to tell the immune system, and specifically the T cells, it's trying to tell the immune system there's a protein here that shouldn't be here. So if you have an infected cell, this is one way that we commonly get rid of infections. And with a tumor cell, what happens is in the middle, you see that MHC and the T cell receptor, this middle signal that's going between the tumor cell and an immune cell. That's actually telling that immune cell there's something here that shouldn't be here. And that's a protein that's kind of sitting on this receptor. On the sides here, what you'll see are what are called checkpoints. And these checkpoints, what they're trying to do is actually stop the immune system from revving up too high, or even stop us from attacking our own cells. So these checkpoints, this was a fascinating story. If you want to watch a great documentary, I watched it on a Delta flight a few years ago about Jim Allison, who really discovered that this system exists in our immune system, where we have a way of saying stop to the immune system so the immune system doesn't over rev up. But what happens is, like a lot of the systems that we see in biology, cancers will hijack those systems and use it for their benefit. So how do they use it for their benefit? Well, essentially what they do is they overexpress some of these signals and they keep the immune system out. So on the right, this is just sort of a simple cartoon that's kind of showing you the same thing. There's a stop sign. So these are negative interactions between the tumor cell and the immune cell. And what we see are these monoclonal antibodies. So any drug, like what we saw with bevacizumab, or Dr. Shergill mentioned cetuximab, when you hear a drug that ends in mab, that's a monoclonal antibody. It's a very specific target. So we can specifically target this receptor, or this ligand. We can specifically target these and try to block the stop sign. So essentially, what I often will tell patients, it's like, imagine your cancer cells, and we saw wonderful pictures of all of these cancer cells. Imagine they have a force field or a shield around them that's not allowing the immune system to come in. Well, what happens is when we have an antibody to that, we allow that to be exposed to the immune system. And it sounds great. It's like lighting a match for your immune system, and then your immune system can take care of the cancer rather than relying on a lot of the drugs that we just heard of, the chemotherapy that can be, I'm sure there are people in the 147 participants that have been through chemotherapy and know just how difficult it is to get through this chemotherapy. So what is it? What I'm going to be specifically talking about are these checkpoint inhibitors. They have completely changed the field in melanoma. Like our former president, Jimmy Carter, had melanoma up to the brain and got checkpoint inhibitors, and it's done quite well. It has completely changed the field of some of the cancers that we see in the gastrointestinal world. But are we there yet with these appendix cancers, which is what I want to get at? So checkpoints are checkpoints within the immune system, and specifically within the T cell immune system, that says, hey, stop, and doesn't allow the immune system to actually come in. So if we have antibodies to that stop signal, we can essentially rev up the immune system and try to get it to recognize your tumor cells. Why is this so important? So probably many of you heard about this, and I got asked about a lot of this. This was in June of this year. Cancer disappeared in all patients. So this was 14 patients that were presented at our American Society of Clinical Oncology, and this was groundbreaking. These were stage 3, predominantly rectal cancers that were what are called MMR deficient. So they had a marker that said this approach to blocking these checkpoints and allowing the immune system, it worked in every single patient. So who are these patients, and what is MMR deficiency, or what is microsatellite instability high? These are actually things that we can find on some of the studies that Dr. Shergill mentioned with this NGS, or next generation sequencing. For the patients that are out there, you may have been called by Tempus, which most of my patients think is like a solicitor, but it's actually the company that we use quite a bit, or Caris, or Foundation Medicine. These are the companies that are really at the forefront of doing this large panel of different tests to figure out what's specific about your cancer, that we may have a key that can unlock some potential for some of the treatments that we have. So that's why this was important. This was incredible. 6 months of this checkpoint inhibitor, and they got something called dostarlimab, but it was basically blocking this right here. This was enough to make their cancers disappear. And in appendiceal cancer, Dr. Shergill says she hasn't had one. The literature says 2 to 3% of all appendiceal cancers will have MMR deficiency. So what is MMR? Here you can see listed the 4 main mismatch repair enzymes. So these are enzymes that all of our cells have, that if the DNA makes a mistake, they'll go in and fix the mistake. And just to give you, I know we have a pathologist on the call, so I'm going to do my best to explain the pathology. But basically, if you see dark spots, the protein's there. If it's light, like in the upper left and the bottom right, if it's light, the protein's not there. So if you are missing the protein, you're what we call mismatch repair deficient. And these are the patients that we know it from other cancers like colon cancer, or even pancreatic cancer or stomach cancer, but predominantly colon cancer. If you're in that 7 to 10% where you have this missing, either because you have something called Lynch syndrome, which is a familial cancer, or because it just disappeared in your cancer cells, we know you will respond to these checkpoint inhibitors very commonly. In fact, sometimes, in some cases, more than half the time. And I want to get out why that's so important, because it's not just like chemotherapy. It's great. We can shrink the tumors down, but it doesn't last forever. And I think that's one of the critical things. So 2 to 3% of all appendix cancers will have a deficiency in one of these proteins. And in that Memorial Sloan Kettering, that New York study that I showed you where all the cancers disappeared, they were required to have at least one of these proteins missing, and often two will be missing together because they need each other to sort of show up. Okay, so this is new research. This was actually out of Wake Forest that just was published a little over a year ago. And this is trying to get at, can we get better? Can we take each of your appendix cancers and say, are you going to respond to checkpoint inhibitors or this immunotherapy? And this was a feasibility study to show that this can be done. One of the hard things in a laboratory is when we take imagine we take your tumor out and we study it in the lab, we've lost your immune system. So I think this is one of the real challenges from a laboratory standpoint in studying how immunotherapy works. But immunotherapy has really changed the game. It's really changed what we do. And this gets to the why immunotherapy. So for those of you that know Stephen Jay Gould, he was an anthropologist at Harvard, and he's an exceptional writer. And this is his own personal story. And I think I think the title alone, to me, explains why immunotherapy is so important. So the median isn't the message. What do I mean by that? Historically, you've seen a lot of these survival curves. And for those of you that are patients or the family members of patients, you go, well, I don't care about, all of these people. Who am I and where am I in this curve, right? And this is the difficulty of being on the forefront with physicians or with the patients, because what we really care about is who are you and how can we treat you and how can we manage you best? Well, what happened with Stephen Jay Gould is he was diagnosed with another cancer that a lot of our surgeons treat called mesothelioma and peritoneal mesothelioma. So his was in his abdomen. And he had surgery, I think it was in 1982. And what happened was the median survival for patients with peritoneal mesothelioma was 8 months. Treatment didn't work very well. It's a lot, probably like some of the conversations you've had with some of your doctors, where we just sort of say, we don't have a lot of information, this is rare, and this is all we really knew. So Dr. Gould, and you can Google this article, it's a short article, it only takes you a few minutes to read. But he just writes so beautifully about it. What he realized was that statistics didn't just tell the whole story. This simple median survival didn't tell the whole story. And the reason that we use median survival in oncology is often because we don't want to skew our data by the people that do exceptionally well. And you go, well, why don't we want to know about those people? Well, historically, we just didn't know why they did so well. Now, in the era of immunotherapy, those are exactly the patients that we're trying to treat, the ones that do exceptionally well. So what Dr. Gould did was he went to the Harvard Library, checked out some books because this is the 80s, and starts looking at the data himself. And what he realized was that on that survival curve, there was something called the tail of the curve. There were a percentage of patients that just lived and looked like they were essentially cured from their diagnosis of peritoneal mesothelioma. And this becomes important because with immunotherapy, we have the same concept. We have this group of patients that even if you have metastatic disease throughout your peritoneum, and we give you immunotherapy, let's say for a year, we have essentially trained your body and your immune system to be able to manage the cancer itself. And you will see this tail of the curve. So why immunotherapy, why it's changed the game is because not all patients get benefit. So in appendix cancer, I just showed you, 97% don't have the right marker. But I also want to impress on you, we aren't perfect at knowing what those markers are. We have a few that are okay. There's something called a tumor mutational burden or a PD-L1 stain. These are okay, but none of them are perfect. I think MMR deficiency or MSI high which we'll often use synonymously, is the best marker we have. So the why, I think, is because of that long response. And essentially, we hate using the term of cure, but I would say a durable response that can last years. So moving forward in appendix cancers with immunotherapy, are there other ways that we can use not just a single checkpoint inhibitor? Are there other ways that we can try to essentially exploit the body's immune system to be able to recognize your tumors? And this is where the field is really going in immunotherapy. Can we expand those 2 to 3%? We saw that Wake Forest study where they tried to use in the lab a prediction model. Can we combine chemotherapy with immunotherapy? We're seeing this in a lot of other cancers: breast cancer, lung cancer, stomach cancer, now bile duct cancer. We're seeing this approach happening. We really need to better understand predictive markers so that we can really personalize the treatment for every patient. And then, of course, clinical trials is so important. I'll end there. I have 14 minutes and 45 seconds. And I do want to thank, once again, all of the patients, all the family members out there. Thank you for being there with us and allowing us to care for you.
Thank you, Dr. Gilcrease. Appreciate you being here with us today, particularly taking us through immunotherapy, which has got so much excitement ongoing. It's now my privilege, actually, to introduce the president of the board of directors of the ACPMP Research Foundation, Jim Carroll.
Thank you, Dr. Levine. It's a pleasure for me to be here today and share my story, and also to share the story of the foundation. I'll start with thanking Dr. Lambert, Dr. Levine, Dr. Taraga, and the planning committee for their collaborative efforts to bring such a wonderful team here today. My journey began in 2006 when my best friend, Dutch Culbertson, was diagnosed with appendix cancer and subsequently lost his battle. At that point in time, his wife Judy and I set about to try to figure out a way to make a difference. And we were very fortunate that in 2008, we discovered the newly formed ACPMP Research Foundation. And the foundation was formed by a group of patients and caregivers. Primarily, Lisa Luciano was the guiding force, and that group, along with Mike Dvorsky, and that's when we started our journey. Next slide, please. Oops. So what we are, we're a 501(c)(3) organization. The primary mission has not changed much since 2008, and it's really fundraising, which is the lifeblood that drives research and education with the hope of someday finding a cure. Our foundation is made up of the people on this screen. It's a small group: Judy, Deb, Heather, and myself. And we wear a lot of different hats. And then we have an outstanding patient advisory council that serves a group of volunteers that assist us with providing guidance, providing support. And next slide, please. We're also fortunate to have an outstanding medical advisory board chaired by Dr. Lambert. You can see the scope of outstanding doctors, oncologists, specialists, medical oncology, pathology, and prolific researchers that are part of that group, many of whom you will be hearing from today. Additionally, we're extremely excited that this year we formed for the first time our scientific advisory board, which will be chaired by Dr. Halawate. Sorry, Dr. Halawate, if I hurt your pronunciation there. By Dr. Overman, and also Dr. Vatanopoulos from that entire group that will be supporting us with the scientific advisory board. that group is enabling us to bring our grant process in-house. So traditionally, we were relying on NORD to do the RFPs, and quite frankly, it could be a challenging and cumbersome process. And now we're hoping to stream that out a little bit and bring it in-house. And you'll be hearing soon about our RFP process, which we hope to get off the ground soon, and we'll deliver results in 2023. This year, we were fortunate enough to get 4 grants processed and out the door for approximately $200,000 plus. Our approach to research has always been kind of the same. We're looking to identify meaningful research through our RFP submission process and focus on basic science, foundational medical research that can be used to support robust studies, phase trials, and be seed money to lead to further funding of a variety of other types of research. So we're very proud of the fact that we were able to get out year to date since 2008, $1.5 million in funding, and that's broken up by 22 grants within the United States and for a little over $1 million, and $500,000 in grants internationally, 10 grants. And as I said, over $200,000 went out the door for funding this year dedicated to solely to appendix cancer research. From a scope of services that we offer, we have always tried to host patient and physician educational symposiums like today. Here's a small list of some of the things that we've done in the past, and we will continue to do these in the future. Additionally, we fund physician scholarship programs. So we try to identify many of the key important symposiums in the industry, and we try to fund for physicians who may not have been able to attend them. We fund scholarships for those programs and make sure that we're continuing to grow the expertise from year to year. How we support our initiatives and our programs, it's really a wide range of fundraising peer-to-peer events, everything from Facebook and Instagram to our primary national walk that we hold around Father's Day, to smaller events of bake sales, pub crawls, golf tournaments, anything where a volunteer steps up and says, hey, I want to do something. We try to facilitate an event that we can raise money that we can eventually convert to research and education. There's a variety of resources that we list on our website, helpful resources like links to online support, patient support organizations. So we continue to try to develop our online presence in order to be kind of one-stop shopping for the appendix cancer patient and medical community. We also support various patient empowerment initiatives, and we have a new patient guide. We identify clinical trials. We are trying to hopefully get the patient registry off the ground, so stay tuned for that. And we have master list for finding specialists. So in closing, I would thank again those speakers that are here today contributing, and invite everyone to join us in the fight. Become social. We've got a lot of resources that we're trying to get the message out, create awareness, make sure that newly diagnosed patients know where to go and can find information out as easily as possible. So thank you very much for the time today, and look forward to the balance of the presentations today.
Thank you, Mr. Carroll. That's actually great. And, the idea that what you put together and has led for these years is really led to a fair amount of work. And this symposium is just one more, I think, capstone into what's been done. And as somebody who's been a recipient of some of the funds, the seed funding that comes from this organization, I cannot emphasize enough how important that is to move research forward for this disease. Now it's my privilege to introduce Dr. Kirsty Flatmark. And I believe this is the third time we've been at a meeting together in the last month. So she and I seem to be orbiting in the same circles, which is great. Dr. Flatmark is a professor of surgical oncology at the Norwegian Radium Hospital. She comes to us from Oslo, Norway. And she is actually, I think, where the rubber is currently meeting the road in terms of some new immunotherapeutic options for patients with pseudomyxoma. Dr. Flatmark, the floor is yours.
Thank you very much. Can you hear me?
Yes, please go right ahead.
Great. Okay. So could I do my slides myself? Let me see. Yeah. Okay. So I'll briefly introduce pseudomyxoma peritoneae, although that has been done before. I would like to acknowledge previous grant support that we've had from ACPMP through NORD previously, and just briefly show how some of these results have been very important for our ongoing research in the field. I'll show how our research provides rationale for the peptide vaccine that is the main topic of my talk. And I'll briefly introduce you to the Pseudovax phase 1 trial. So pseudomyxoma peritoneae is a very strange disease. It's rare. And as is indicated here, it arises from appendiceal tumors that rupture to seed mucin and tumor cells into the peritoneal cavity. And these are some examples. We've seen many more through the different talks today, where we see that many patients have extensive distribution of these mucinous tumors in the peritoneal cavity. So given that quite a large number of patients have extensive disease, I think it's quite amazing that we are actually, by providing treatment with cytoreductive surgery and hypothermic intraperitoneal chemotherapy, we can cure about half of the patients. This yellow line shows a large study in 2012 where we see this is the so-called disease-free survival, where half of the patients are actually disease-free after a long period of time. This is a small study that we did in Norway in our own cohort, and although our numbers are much smaller, we actually see the same thing. The problem is that for patients who do not have resectable or disease, or if they recur, we don't really have very good treatment options that have been illustrated nicely by my colleagues previously today. So how do we approach this huge challenge in a rare disease? So one of our I believe important efforts has been to try to collaborate throughout Europe through the ACPMP cost action, which we initiated and was funded by the Horizon 2020 framework. This is a network where we have been able to gather and discuss PMP and try to improve research that is ongoing in Europe. Regretfully, COVID has prevented many of our planned meetings, but we still have created a very nice, robust network that we will have draw on for many years to come. Our team in Oslo has also worked extensively on experimental models. These are models that we have developed, established from patients with PMP, and these are immunodeficient models, but we can, in these models, study different new drugs and treatment strategies. And we believe that this is an important tool also in the future. Thirdly, and I think this has been extensively mentioned already, there are some key mutational drivers, the KRAS and GNAS mutations in pseudomyxoma peritonei and in appendix cancer. And apart from that, we actually don't really have a good overview of the mutate or the molecular landscape of PMP. And this is another challenge that we will have to face in the time to come to try to get a more complete overview. And this has been the topic of the first grant that we had from ACPMP in 2015. At that point, we were working hard to do molecular sequencing, DNA sequencing and RNA sequencing of tumors from patients. And we have worked with a large cohort, almost 200 patients, which is quite substantial for Norway. And again, our main findings are, not surprisingly, KRAS and GNAS mutations. We are still working to understand the RNA sequencing data. So this will come, and we're hopefully publishing this in not so long. The second topic of this grant was to study some new in vivo, some new therapeutic strategies in vivo. And we studied anti-angiogenic drugs. This was published, and we've also studied a new KRAS inhibitor. And these data are close to submission at this moment. A second grant was awarded to our group in 2020, and in this study we have two main objectives, and it's to establish a ctDNA assay to detect mutated KRAS and GNAS in plasma samples from PMP patients. And we have been able to do this. These are GNAS mutations in a patient tumor, and this is the corresponding plasma sample from the same tumor, for the same patient. These are the mutations as dots in this diagram. Our ongoing work now is to validate this optimized assay to see if we can use it to follow up patients after CRS-HIPEC. And our study has been hampered a little bit by COVID, but we are hoping to be able to use this for the vaccine trial that we will hopefully start in not too long. So this funding has been essential and has been important to help move forward also in the vaccine project. So mutations in the GNAS oncogene are present in many other cancers, in about 4%, but in PMP it's extremely common. So we see these mutations in between 60 and 80% of the cancers of the patients. This gene, it codes for this protein here, which is called guanine nucleotide binding proteinase subunit, or GS-alpha. And we use GS-alpha and GNAS a little bit interchangeably. So this mutation is associated with mucin production. So we believe that this is a very essential feature that characterizes many of these mucinous tumors. So what is a bit strange with this mutation being so common is that nobody has been able to create a successful treatment targeting this mutation. And this has been our challenge. And we started out, I worked together with some immunologists, and we asked the question whether GS-alpha could be a cancer neoantigen. And what is a neoantigen? Well, when cells grow, some of them will die, and some products from the cells will enter the circulation. And some of these proteins from the cells can induce an immune activation of T cells. And if they do, we term them neoantigens. And to study this in PMP patients, we collected blood samples and tumor tissue from 25 patients undergoing surgery for PMP. We did mutation analysis and found that almost 90% of this small cohort had these mutations. There are two specific mutations, the R201H and C, and one of them is more commonly detected than the other. And in our project, what we did was from the blood samples, we would isolate the T cells and grow them outside in the lab and expose them to the mutated peptide, so a small piece of protein which contains the mutation. And the idea was that if the patient had memory T cells, which means that they had seen this mutation before, this stimulation would make the cells start dividing. And this is something we could detect. And we found that these are these two mutations that we can find. And these are the responses in our patient blood samples, which is, according to our immunologists, a quite dramatic response. This is a wild type, and this is a control that's really off the charts. But this is a very solid response from this type of assay. And we concluded that there seems to be a pre-existing immune response against mutated GS-alpha. And all of this is summarized in this paper that was published last year. So if this immune response is there, why do the patients develop PMP? And a possibility could be if the T cells aren't able to move into the mucinous tumor tissue, because that could be possible. So we first examined whether the tumor tissue actually contained T cells. And we found that it absolutely did. Almost all the samples had detectable levels of both CD4 helper T cells and CD8 cytotoxic T cells within the tumor tissue. And this was done by a so-called CyTOF analysis, where we look at the surface molecules on the T cells. So if we have an immune response and the T cells are actually making it into the tumor, why are patients developing PMP? Why does this process go on? Well, it's now fortunate that the checkpoint molecules were introduced by the previous speaker. So what we found was that the T cells inside the tumor tissue in these patients, they express immune checkpoint molecules, particularly two known checkpoint molecules, TIGIT and PD-1. And PD-1 is one of the common targets for some of the immunotherapies that were described previously. And this was also done looking at the surface markers of these T cells. So based on this, we see that we probably don't have enough of these specific T cells, and they're not doing the job. How can we remedy this? Well, we want to make more T cells that can recognize this antigen. And we want to do this by giving the patients a vaccine. And the vaccine will contain these small mutated peptides. It will be injected intradermally and taken up by antigen-presenting cells that will present them to the T cells, and hopefully they will proliferate, divide, as they did in our lab, and then be ready to potentially kill PMP cells. But as we know, they will most likely be inhibited by checkpoint molecules. And therefore, we believe that we also need a checkpoint inhibitor to actually reactivate these T cells so that they can do their job and kill the PMP cells. So what does this look like in the Pseudovax trial that has been illustrated here? So these are PMP cells in the patient with specialized T cells that should be able to kill PMP cells, but they're not doing the job. If we vaccinate the patient, we will hopefully generate more and more specialized T cells, but they will still have these stop signs on their surface, and therefore we will need to treat them with immune checkpoint inhibition to restore immunity to help them, the T cells, kill PMP cells. So this is the scheme for the Pseudovax phase 1 trial that we are hoping to start. This will be a so-called first-in-man trial, where the main outcome will be to evaluate safety and toxicity. This specific combination of vaccine and immune checkpoint inhibition has never been given to patients, although similar trials on different targets have been given. So we don't really expect a lot of toxicity. We will also monitor immune responses. That means that we will measure lots of parameters throughout the trial. And this will be, so we're looking for a signal. We want to know, does this concept work? Because if it doesn't work, there's no point in doing this in many, many patients. So we will do a small trial. It will include only 10 patients, is what we target. And what we will do is to give the patients this vaccine for 3 months, and then we will start the immune checkpoint inhibition here, and the treatment will go on for a year. And these are all these dots are all the measurements that we will do along the way. And regarding the timeline, we received essential national funding here in Norway last year, and this has made us able to start what we call a technical batch, which is what we will do to develop all the analysis tools that we need to make sure that this is a pure, good vaccine product that is safe to inject into patients. And we are hoping still to start the trial in January 2024, but our main challenge is funding. We have had wonderful support from patient organizations in Norway, in the UK, and hopefully ACPMP will be able to support the study. So thank you very much for letting me present our research. I have a lot of people to thank in Norway. This is our team, the clinical team and the research team, and some patient representatives that we are collaborating closely with. I would specifically like to thank our PMP patients who are very generous with letting us do research on their samples. Thank you very much.
Thank you, Dr. Flatmark. I think it's easy for anyone to see just how complicated doing the sort of research that is required to move the ball forward for appendiceal cancer. And it's also one of the things we're trying to highlight is some of the recipients of the ACPMP funding. And actually you got several on the call, including Dr. Flatmark. I'm going to move on to the next talk. And this is actually a talk I look forward to every year. This will be given by Dr. Laura Lambert, who is a professor of surgical oncology at the University of Utah, Huntsman, one of the leaders of this particular program. She's been very active in peritoneal disease for many years. and has really taken a point of view favoring the patient as opposed to some of the research angles, which makes her a little bit, I think, ahead of the curve in a lot of ways. So, Dr. Lambert, can you tell us about what are the papers of the year for this year for appendix cancer?
Great. Thank you, Dr. Levine. And I just want to thank the ACPMP Research Foundation and all the people who have joined us today and my co-moderators and the speakers. I really love this event. As Dr. Levine has said, my passion is really taking care of people and taking care of their families, and particularly in this very challenging area and disease. And so I just love this event, and just so everybody knows that you're not alone. There's a lot of people who are dealing with this disease, but also a lot of people who care very deeply about treating it and helping and those who are afflicted by it. So what's new in 2022? Well, I usually start with a review of what the publications look like during this year. And as you can see, in 2021 for appendiceal cancer, if you just do a PubMed search, you can see that we had the second highest level of publications ever last year, and we're projected to get up to 245. And interestingly, for PMP, if you do a PubMed search, we actually had the highest by a lot number of publications related to PMP at 125. And based on just my crunching some numbers on the back of the napkin, we're projected to get up to about 105, which would be the second highest number of publications. So still a lot of interest in both of these aspects of appendiceal tumors and the treatment and understanding the genomics. And I think you can hear just from the talks that have been given today how exciting things are, and how we're trying to bring in other areas of cancer treatment, such as immunotherapy, to really understand this disease and to treat it better. The highlights of this year, as I reviewed the literature, are still focusing on increased awareness, optimizing treatment, defining the pathology, improving patient selection for the treatment options that we have available, advancing surgery and intraperitoneal treatments. And there was a number of questions that were pre-submitted about that, research, obviously, and clinical trials. And I'm just going to take a few moments to highlight just a handful and try to hopefully get us back on time a little bit. So one of the frequently asked questions that we hear, and it actually came up in the pre-submitted questions, is how often does low-grade appendiceal cancer or tumors become high-grade? And when that happens, how does that impact outcomes? And it just so happens that Dr. Levine and his colleagues at the Wake Forest Institute published a paper on that exact question this year. I actually got asked this question yesterday in clinic. And they looked at 65 patients who had low-grade appendiceal neoplasms that ended up having a second HIPEC surgery, and found that at that time, 11 of them had actually converted to a high-grade pathology. So that gave them an estimated 17%. And I think this is really the first time that anybody's put a true number on that. I think all of the surgeons, medical oncologists who treat patients with appendiceal neoplasms have seen this, but to really understand how frequently it happens. Some of the risk factors that they identified were an elevated CEA tumor marker. Interestingly, if someone had a splenectomy at the time of their first HIPEC, and then if they got systemic chemotherapy as part of their treatment, not to suggest that having chemotherapy caused the conversion, but perhaps that these were patients who were pre-selected based on other reasons to get systemic chemotherapy and may have actually had high-grade tumor at the time that they were being treated. The time to a second HIPEC was different, depending on whether people had a high-grade tumor at the second time. Interestingly, it was actually longer, 4.4 years versus 3.7 years, compared to those who did not convert to a high-grade tumor. And most importantly, the conversion did not seem to impact the ability of the group at Wake Forest to achieve a complete cytoreduction. And they did not see an impact on overall survival from the time of the first HIPEC. So it was 8.8 years versus 9.5 years. But they did see a decreased overall survival after the second HIPEC, which is not surprising since the second HIPEC happened later than people who did not convert. So very interesting. Thank you, Dr. Levine, for bringing that information to light. It makes it easier to answer questions in clinic. The next, one of the more frequently asked questions has been, what is this thing called iterative HIPEC? And we're going to hear from Dr. Taraga about that because he's really been the pioneer looking at that. And I want to just take a moment and look at a couple of papers that were published that looked at repeat HIPEC and kind of make a distinction between that and iterative HIPEC. So Dr. Sardi's group from Mercy Medical Center in Baltimore looked at what they termed it iterative HIPEC in their study, but it was really more repeat HIPEC for patients who had a recurrence. And what they found was that there was a benefit for patients who had repeat HIPECs for low-grade mucinous neoplasms and high-grade mucinous neoplasms, but not for the signet ring cell. And as Dr. Mastraggi explained, those tumors really are sort of in a category of their own. They do tend to be a little more aggressive and they're a little bit more difficult to treat. But they also found that there was a longer disease-free interval for patients who had a second HIPEC, which makes sense because you're doing a second cytoreduction. And again, going back to the Wake Forest Institute, they looked at their experience with repeat HIPEC for the low-grade mucinous neoplasms and similarly found better outcome with longer time to recurrence. And again, reiterating their other paper, the timing of the second HIPEC did not impact the survival from that. But what iterative HIPEC really is something different. And this is, again, Dr. Taraga is going to talk about this. Really, this is multiple HIPECs often done in the setting of cancer that's not resectable to try to use the HIPEC in the way that we use systemic chemotherapy to treat the cancer prior to the surgery, or to hopefully get somebody who may not be a candidate for a complete cytoreduction to be able to get to that point. So we are starting to see the use of iterative HIPEC for high-grade appendiceal. In this study was with the ex-goblet cell cancer, or the goblet cell cancer. I think other people are starting to use it in the setting of high-grade appendiceal cancer, and also in gastric cancer is the other place that we're seeing its use. And again, he'll speak more to that later in the program. And then another frequently asked question is, what the heck is this Hammond? And I'm so glad that Dr. Mastraggi did touch on it briefly and really showed some beautiful pictures that I think just express things in more than 1,000 words than anybody could. And then the other question is, what do we do about it? And it actually turns out that he has published on this year as well. And he and his group looked at 35 cases of this Hammond, which again, he showed you, which has the architectural features of lamin, meaning that it's pushing through that boundary, but not invading. But those cells look much more abnormal under the microscope. So it has that high-grade cytology. And interestingly, because this is sort of the question that we get asked all the time, so how do we manage that? Do we treat it like a cancer, or do we treat it like a low-grade mucinous neoplasm? What they found was that it actually exhibits similar biology to the low-grade mucinous neoplasm with a very low risk of recurrence if confined to the appendix. But if there's a perforation, as he showed in those nice pictures, there is a risk of pseudomyxoma developing, and that pseudomyxoma will often be in that middle grade, that grade 2. So we tend to treat these as lamins, and that's the way that we do treat them here at the Huntsman. And according to the Chicago consensus that Dr. Taraga was instrumental in putting together, that's the way the recommendations are to manage these tumors. And then finally, I can get my slides. So what should we do about acute appendicitis? How should this be managed? And this is a question that's coming up, maybe not so much from this group through people who already have appendiceal cancer, but this is a really important question for general surgeons and surgical oncologists about the management of appendicitis, because there's been a real shift in the general surgery world to trying to manage appendicitis non-operatively. I have previously shared with you this data that demonstrates a significant incidence of neoplasms, tumors of multiple different types after what we call an interval appendectomy that has been performed for people who have complex appendicitis, meaning they developed an abscess or got significantly ill from their appendicitis such that they were initially managed with antibiotics and maybe a drain tube, and then gone on to have their appendix removed. And you can see on this slide that there is an incidence that ranges from 9% to almost 30%. in patients that have complex appendicitis and go on to have an interval appendectomy after that. And this has really become the argument for an interval appendectomy. And in addition, people have also tried to look at risk factors for people with complex with appendicitis. What are their risk factors for there being a tumor involved there? And a number of studies have pointed out age as one of them. And numerous reports have now come out showing that people who are over the age of 40 who have a complex appendicitis should definitely have their appendix removed because they are at high risk of having a tumor of some sort, primarily related to the appendix. And this is a study by Skandalis et al. That looked at, that demonstrated this increasing risk of a tumor being present when somebody has appendicitis based on age, but also showing that there's starting to become a differentiation between the adenocarcinomas or the lamin and the incidence of neuroendocrine tumors, which are increasing significantly in younger people. We don't often talk about these neuroendocrine or carcinoid tumors in this setting because they are treated very differently and tend not to cause pseudomyxoma and tend not to spread through the abdominal cavity as much. But there was a recent study that came out by Salazar et al. Looking at the National Cancer Database, which is an incredibly large registry of all cancer patients in the country, or almost all cancer patients in the country. And they looked at the patients who had surgery for presumed right-sided colon cancers and found that actually 5% of them ended up having appendiceal cancer. So this was not an insignificant number. And these patients tended to be younger, and they tended to have advanced disease at the time of diagnosis, so cancer that had already spread away from the appendix at the time of diagnosis. And similar to the previous study that I showed you, well, first I'll just say that what they noted was that the incidence of right-sided colon cancer was actually decreasing over that time period, but the incidence of appendiceal cancers was rising. And what they found was that, similar to the previous study that I mentioned, that there's an increasing incidence of neuroendocrine or these carcinoid tumors, particularly in patients less than 40 years of age, actually. But there was an increasing incidence of appendiceal cancers across all age groups, and the adenocarcinomas and the low-grade mucinous neoplasms occurring in the older patient population. So this was a study that came out recently. It was published in the Journal of the American Medical Association, and this caught the notice of some members of the ACPMP, and this was brought up to Deb Shelton, who brought it to my attention, because people were concerned that this review article was recommending that people that have appendicitis just have their appendicitis treated with antibiotics. And people on this, in this forum were very worried that people with cancers would be missed. And so Deb brought this to my attention, and we agreed with that concern. And so we actually wrote a letter to the editor to try to convey the need for vigilance, that not all appendicitises are the same, and that there is an underestimation or lack of awareness of the risk of appendiceal cancer. So if you follow this algorithm down, you can see here that the authors were recommending for patients who have, this is for acute appendicitis that is not complicated, so this is just straightforward appendicitis. Either they looked at some risk factors, whether there was a little appendicolith, which is a little bit of stool in the appendix, or a mass effect. Then if people had these high risk features, they were definitely recommending that people get an appendectomy. So they were focusing on that. They were aware of that. But then if the answer was no, then they were saying that people could either have an appendectomy or antibiotics. Unfortunately, our letter sent on behalf of the ACPMP was not accepted for publication. But more recently, a long-term follow-up study came out, published in the New England Journal of Medicine, following up on a study where people were randomized either to have their appendix removed or just have antibiotics. And what they found was that patients who just had antibiotics, almost 50% of them actually ended up having an appendectomy at some point for recurrent appendicitis. And this is much higher than what we thought it was going to be originally. And if you look through the supplemental data that they provided, there was a very low, but not zero, almost a 1% incidence of people having a tumor in their appendix when they had it removed after having non-complicated appendicitis. Again, a lot of them were neuroendocrine tumors, but there were a number of lamins as well. And so we were going back to that other study by Salazar. There were some notable comments in that study. I just want to share these with you. And they said, quote, "It is possible that decreased rates of appendectomy may be partly responsible because appendectomy should eliminate the risk for appendiceal cancer." So saying that decreasing rates of appendectomy are leading to the higher rates of appendiceal cancer that we're seeing because people are having their appendixes removed. And then again, with regards to the increasing rate, although it could be associated with improved resolution of diagnostic imaging, it has been previously described that most appendiceal cancers are discovered during surgery. Therefore, clinicians should consider the possibility of appendiceal cancer when assessing patients with acute appendicitis. And going back to that review article, they did describe some radiologic findings that should prompt people to have their appendix removed if they have appendicitis. And then finally, although the probability of resolution with non-operative management of appendicitis with an underlying neoplasm is uncertain, resolution without surgery could lead to the delayed diagnosis of cancer. So basically what they're saying is if there's a tumor there, they're not as sure that appendicitis will resolve with antibiotic treatment, but without having surgery, if there is a tumor there, this will result in a delay in diagnosis. And so I was asked to write an invited commentary to that article, the Salazar article, with those comments. And so this is what we were finally able to get our message out on behalf of the ACPMP community and the community of people who are afflicted by appendiceal cancers and tumors. And this is, I just want to share this comment from that commentary. Because of its diminutive size, lack of essential function, and usually easy removal, serious concerns about the appendix are often dismissed. However, despite the seemingly insignificance of this organ, tumors and cancers that arise in the appendix are devastating and life-threatening, and once spread through the peritoneum, require some of the most morbid surgical and oncologic interventions available. As a rare tumor, cancer of the appendix is not often considered in the differential diagnosis of acute appendicitis, but with the rising incidence, as demonstrated by Salazar and colleagues, our awareness of this easily treatable, potentially life-threatening condition needs to as well. And this is really the message of the ACPMP organization. And I think the message that we're hoping to share with other healthcare providers and increased awareness through word of mouth. I know that people who are dealing with this, when you hear about other people who have appendicitis or a tumor in their appendix, you're encouraging people to get to the help that they need. And that's what we just need to keep doing. We just need to keep spreading the word and sharing the education. So what's coming in 2023? Well, the BROMAC trial, hopefully, we're going to hear about that in the next session from both Dr. Morris and Dr. Levine. This is something brand new that's coming, multivisceral transplantation, and we're going to get to hear from Dr. Vidaya in the next session as well. We're going to hear again from Dr. Taraga about the role of iterative HIPEC. We're going to hear more about PIPEC from Dr. Raouf, which is pressurized intraperitoneal aerosolized chemotherapy for the management of peritoneal carcinomatosis. We've already heard about immunotherapy and Dr. Flatmark's trial that hopefully will come to fruition sooner rather than later. It's very exciting. And again, increased awareness and prevention. We just need to keep getting the word out and getting the message out. And so with that, I'm just going to leave you with my final words about hope. I don't know if people have been watching The Rings of Power on Amazon, but this was a quote that I picked up on in the last episode, that hope is never mere, even when it is meager. And when all other senses sleep, the eye of hope is the first to awaken and the last to shut. And my hope is that, as a community, we will link arms together, like Dr. Mastraji's picture, and be able to just push the boundaries of our understanding and knowledge and treatment for appendiceal cancer, and really make some cancer history here. And with that, I'll conclude my remarks.
Thank you, Dr. Lambert. Most appropriate to quote something along from The Lord of the Rings. I think that's we're going to all slay Sauron and appendiceal cancer. I think that's great. Our next segment is actually a Q&A session. And I've got, if I according to my clock, 3 minutes to do it. I might take a few extra minutes before we get started on session 2. We've got some experts on the line who we've heard from before, and I've got a list of 4 pages of questions. I would like to answer them all. I cannot answer them all in the time allotted, and I'm going to try to engage our experts on the panel as we could. Let me start. One of the first ones that came up and came up more than once, and this is if the CEA is in normal range, can cancer still be present? Is there still need to do a CT scan if you have a normal CEA? Dr. Sturgill, you mentioned some of this in terms of follow-up and how you treat patients and how you follow them. Could you mind making a comment on that for our questioner, please?
It was in light of how difficult it is to follow, because CEA is not always elevated. So there are certain CEA producing cancer. Other tumor markers that I follow are CA19-9 or CA125 in patients, but not all appendix cancers produce these tumor markers. If a cancer produces that, do follow over time. Could you still have cancer if these markers are negative? Yes, you could. So that's why we need other modalities like the molecular testing and the CT scan to follow it.
Very good. Thank you. The next question comes in. This is tailor-made for Dr. Mistragi, so we'll answer to him. And this is a patient who has, unfortunately, suffering with a Levine tumor with peritoneal dissemination. She's undergone HIPEC. She's had a recurrence, but it was diagnosed as Levine. And the question that she asks is this a cancer? Is it not a cancer? And what should she tell people that she actually has?
So as I talked about, these tumors straddle what we believe to be cancers and benign, but most people place them into the category of a slow-growing progressive cancer, particularly because if you don't treat them aggressively, they do cause significant morbidity and eventually mortality. So yes, they should be viewed as a slow-growing cancer, especially once they have spread throughout the abdomen.
All right, thank you. Another question, and I'll ask Dr. Gilchrist to weigh in on this one if we could. What are the options for slow-growing cancer cells? Does chemo work here, and is immunotherapy an option?
He may have had to step away. So maybe right. Dr. Sturgill could answer that.
It looks like Dr. Gilchrist is muted.
Dr. Sturgill, help us out.
I'm so sorry. The question was for low-grade or slow-growing cancers, is immunotherapy an option?
Well, the question is, for low-grade or slowly progressive tumors, is chemotherapy an option, and does immunotherapy work?
Yeah, so chemotherapy works best on fast-growing cells. It targets cells that are fast-growing. As we heard today, cancers are not pure, so low grades can become high grades. So there could be high-grade component where it works on, but generally, very broadly speaking, for low-grade, chemotherapy is not the first thing I would think of. As far as immunotherapy, again, we heard the talk of how we can use it in this cancer. It's not standard currently, but I look forward to all the advances to be able to use it for appendix cancers.
All right, and this is a question, I think, which is tailor-made for Dr. Flatmark. Will a vaccine be available soon for those who have appendix cancer, and what's keeping them from moving forward?
Yeah, so I think it's still going to be some time before the vaccine is available for most patients with PMP. First of all, we have to figure out if it works, and we don't know that yet. So that I think is the most important step forward. And if we keep our timeline as planned, we could hope to have an answer by 2025, 26. But research takes a lot of time.
All right, but the work continues, and that's excellent. I'll take the next question here, which is, what are recommendations for the best time to do a repeat debulking after a recurrence of appendiceal mucinous neoplasm? That's a complicated question. It depends upon If it's low grade or high grade, what other therapies have been utilized? Usually we wait at least a year between cytoreductions and HIPEC. And if you have to operate on somebody before then, the outcomes tend to be relatively poor. So usually we'll say at least a year, hopefully longer than that. And then a question I'd like to throw out, I think, to the group. The first question actually we got from anyone is, what doctor treats appendix cancer? And what you see before you is a variety of doctors of various types and people supporting them. Surgical oncologists in terms of the surgery, medical oncologists for systemic therapies, pathologists for accurate diagnoses and retreatment staging. Also not in the pictures are radiologists who are going to be taking the pictures, and the imaging gastroenterologists who are going to be working in terms of the endoscopy. And if nothing else from this session, I hope you get the idea, and everyone gets the idea in the audience, that treatment of patients with appendiceal cancer, this is a team sport. This is not for individuals. And I think we ought to probably leave it in the hands of people who've got large teams. One more question I'll throw out for Dr. Lambert. There's a question of, why are surgeons reticent to debulk mucin and remove tumor when HIPEC is deemed not to be an option due to extent of disease?
Yeah, that's actually a really good question. And it's a really challenging part for the surgical oncologist to know what, as much as we love to operate, we want to make sure that when we do an operation on somebody, it's actually going to be helpful. And we really have to weigh that potential help with the potential risks of the surgery. And if we're in a situation where, there's a person for whom don't think we're going to be able to get a complete tumor removal such that HIPEC will be helpful, then we're really starting to be in the realm of what we call a palliative intervention. So is a surgery to remove part of the tumor actually going to be helpful? Is it going to improve a person's quality of life? Is it going to give them more time? And what are the risks of that surgery compared to those potential benefits? And this is a very challenging area. This is not something where there's a lot of data or trials that we can look at. This is really based on the experience of the surgeon that's seeing the person and helping make those decisions. And so that may be a reason why surgeons are hesitant. Really, when we operate, we want to make sure it's going to be helpful and not harmful. And help can come, that help can come in multiple different forms. And it may not necessarily require a HIPEC. So each case is really taken on an individual basis.
Thank you. Another question for Dr. Mizraji, which is acellular mucin from a Levine tumor considered a pre-malignant condition?
I wouldn't say it's pre-malignant. It's just concerning. When you have acellular mucin, it means it's spilled mucin, and under the microscope, we don't find tumor cells. That could mean that there were no tumor cells in that mucin, but it also could mean that we just didn't detect them. So it is better that we find no tumor cells, and it could potentially be that there were never tumor cells in that mucin and everything will turn out great. And that's what most studies show. But every now and then there is someone who does develop full-blown pseudomyxoma, because remember, what we're looking at is under the microscope. But what we can't determine is what was left behind. And so if we didn't get all the mucin or there were tumor cells left behind, those tumor cells can recur. So it's better than finding tumor cells at all, but it's a guarded prognosis where, it's better than finding tumor cells, but it's sort of a watch and wait sort of situation.
All right, I think I don't want to take any more. We've got several pages of questions yet. I think we could go on for a long time, but we need to get to the next session. So for all of the speakers for the first session, I'd like to thank everyone for participating, for hanging around to answer the questions. And at this point, I think it's time to transition to the second phase. Everyone is welcome to go grab a snack or a lunch. And I'm going to turn the proverbial dais over to Dr. Lambert for the second session of the three. Thank you all, and I appreciate the privilege of being here.